All right. Well, I don't want to delay this because we're super excited to hear what Dr. Timmons has to say, but good evening and welcome to tonight's Wu University's webinar, Prostaglandins, the Paradigm in Glaucoma Therapy with Dr. Jim Timmons. You can advance it.
Oh, okay, sure.
Thank you.
Hold on. There we go. Oops.
You can go back. So I'm your host, Dr. Jennifer Stewart, and thank you to Taya for exhibiting at tonight's event. So it is my very, very, very great privilege to introduce Dr. Jim Timmons. He's a 1978 graduate of the Ohio State University College of Optometry. He completed his hospital residency at I don't know how to say that, Jim.
Bill Coffey.
Thank you, VA Medical Center in 1979, and then served as Chief Optometry Service until 1985. He then accepted the position of Center Director at Omni Eye Services, Fairfax, Virginia, and served in that role until 1989, when he became Chairman, Department of Clinical Sciences at the State University of New York. While at SUNY, he developed the Glaucoma Institute, a clinical research center, and served as its very first director. In 1998, he accepted the position of Executive Director of TLC and served in that role until 2002, when he co-founded Ophthalmic Consultants of Connecticut, a multidisciplinary referral practice providing secondary and tertiary level care. Dr. Timmons has received numerous awards for his service to the profession and has over 200 publications in glaucoma, dry eye, cornea, and external disease, as well as refractive surgery and new technologies. He's a nationally and internationally acclaimed speaker and educator, acknowledged leader in the ophthalmic clinical education. He serves in professional appointments at several universities in the U.S. and has been a clinical investigator in over 20 NIH, NEI, and post-release clinical trials. He's a good friend of mine, a wonderful colleague, a mentor. I was lucky to have you right down the street in practice. He's an unbelievable clinician, and we are in for such a treat tonight. So welcome, Dr. Timmons.
Thank you so much. Thanks. Lovely to catch back up, Jen. I'm sure we'll catch up again soon here in Connecticut. And thanks to everybody for joining me. These are my disclosures. I think they're relatively pertinent. I think, yeah, pretty close to. That's good. That looks like those folks that I either am on the advertisement or the advisory boards of, on the directorial boards, doing clinical research with, or receive grants from. So they've all been indicated. So let's talk about PGAs, and specifically, let's talk about glaucoma. PGAs sort of wrap a big bow around the world of glaucoma, and I think most of us are probably using them as first-line therapy. I would doubt that that's an overstatement. But I also think it's worth understanding how they got to be that, and also many of the nuances of PGAs. PGAs, I think, typically are looked at as sort of the go-to drug, but also sort of the safe and easy drug. And that's quite true. But there's also the idea of how do we actually measure their efficacy, and do they really work as well as we think they do? So I'm going to start off with a couple of things. This is my lovely older daughter, my oldest daughter. She's lives in Chicago now, but that's she and I in Paris. And this is my younger daughter who just got married this weekend, not in Switzerland, but elsewhere. But that's she and I at the top of the world in Switzerland. So love to travel with the kids, but I also love coming home. This is my coffee stop in the morning on the way to work. So love living by the coast in Connecticut. Um, Everybody has seen this slide before, and I think it's really important to understand that most of these factors do not play a role in the efficacy of PGAs, but there are some things that do. And then we certainly have a mild differentiation by race. Corneal thickness plays a major role in differentiating the effect of IOP. And also diurnal fluctuation in IOP can be a critical issue when we're trying to determine whether a PGA is really working well. And I guess the other concept in glaucoma, which is critically important, is, is IOP really the most important issue? And since it's all we have to measure, and the PGA is giving us that information, what is it doing to help us understand the disease that we're treating? I would argue that if you look at patients with elevated pressure, you're going to end up with really remarkable IOP responses in most patients. On the other hand, if you take a normal pressure patient, you may not get more than 1 or 2 millimeters of mercury difference from peak to trough relative to the effect of the drug. environmental and clinician-induced disease is probably not so important, but I think it's quite critical to understand that the numbers we talk about, PGAs average 30%, that's over the diversity or the diaspora of IOPs that run anywhere from 15, 16 up into the 30s. The maximum response tends to be in that 25 to 35 range, whereas the minimum response is in the normal range. So you have to adjudicate that when you assess success or failure. Also, what's the role of IOP? It's really interesting to note that, only 1% of ocular hypertensives develop a visual field defect every year. And if we treat all hypertensive, we're over-treating anywhere from 80 to 90% of the patient base. On the other hand, it's also really important to know that normal IOP does not in any way exclude glaucoma. So as we evaluate the patient to decide whether we're going to use a PGA as our initial drug, it's critical to understand that whatever that number is that comes up on your Goldman dial, we're going to talk about some other ways to assess intraocular pressure, which I think are far better. But whatever system you're using, if that number comes up and it's 18, you do not want to take a pass on that patient because it's really the optic nerve, visual field, OCT, corneal thickness, corneal hysteresis, tonography that are going to prove or disprove the status of the disease. This is out of the Baltimore Eye Survey. It's probably one of the more important slides tonight. 50% of the patients diagnosed with glaucoma in that study, and this is one of the great studies of all time in the world of glaucoma clinical research, did not have a pressure above 21 at the initial diagnosis of the disease. Eventually, the vast majority, when pressures were taken repeatedly, did demonstrate a pressure above 21. Probably the most difficult patients I have to work with are those who are sent in and have had relatively significant glaucoma damage. I have one right now where the pressure that was being evaluated at the office level was never above 21. And I think it gave the clinician maybe a little false sense of security. I would advise that regardless of what you're going to do as far as starting with your PGA, the real diagnosis is made on the assessment comprehensively of the patient. IOP is what we can impact, and it's a surrogate for the effectiveness of our therapy, but in and of itself, it's not the disease state. These are some of the predictors. We have pachymetry, corneal hysteresis, tonography. A little known one, unfortunately, but probably one of the most important. And every major study, which we'll reference here in a couple of seconds, that has been done in the last 20 years has found that diastolic blood pressure, decreased diastolic, is probably the most significant provocateur as we develop glaucoma, because as you understand, blood pressure goes down, you become a nocturnal hypotensive. Eye pressure goes up at night. I'm sure most of you are aware of those studies from the labs out at Hamilton Eye Center in California. They were the original labs that discovered that. And then subsequently, that differentiation causes a decreased amount of blood supply to the nerve. We don't really measure diastolic BP at night, but you can measure it in the office, and I certainly do that routinely in the initial assessment of my glaucoma patients. We usually get one of the techs or one of the students to do a blood pressure to set the tone for the visit. Just a very brief comment about where we are with the science of measuring intraocular pressure. Everybody understands Goldman pressures have been the definitive pressure for a long time. If you read the original paper, The Trieste by Dr. Goldman, he willingly admits that there are many, many problems with the system that he created, and that it has limitations, none of which we actually really adhere to. Patients with more than a diopter cylinder are supposed to have the axis of the probe into the cylinder axis in order to diminish the irregularity that produces. If it's over 3 diopters, measuring Goldman is probably not so accurate in any dimension. I have a very large teaching program right now. I have students from multiple universities. I think this year I have 8 or 9 schools that we're affiliated with that are sending students to the office for training. And, they're there to really hit the ground running. As Jen and I were talking, I schedule 50 people a day. I do that 5 days a week. We have a very busy office. Students get to see a lot of people. And one of the things I'll notice is in the beginning, until we sort of get them to create a better perspective when they do Goldman, they'll do it, and I'll have the other student do it, and I'll get two very different readings. It's because they're reading two different thicknesses of the Myers. That's probably the biggest flaw with the testing, is that everybody assumes that every measurement's right. I would tell you that almost every Goldmann measurement is wrong, and the question is just how much wrong it is. So there are other ways to do this, but the key is whatever you're going to do it consistently. Even if you're just going to look, taking Goldmann pressures, make sure you get the Myers correct. Get a pattern, make sure that the thickness of the Myers is generally the same after every measurement, and do your best to try to neutralize some of the effects that the Goldmann system have as weaknesses. Corneal hysteresis is a hugely important factor. I think probably one of the most important, actually. And, the Reichert system's been around a long time, something that I think is essential in any glaucoma practice. And I think most clinicians looked at it very favorably when it was getting reimbursed, probably a little less so now. But it doesn't take away from the ability of this device to actually show us really critically important information about predictive values to glaucoma. So one of the first studies ever done was this. So if you look at corneal hysteresis versus corneal thickness or pachymetry, pachymetry is all over the map. I have patients from West Africa. I have patients from the Middle East. I have large bodies of patients from Bangladesh, Somalia, Ethiopia. I have patients from the South Asian diaspora, Pakistan, India, Bangladesh. And I'll get central corneal thickness measurements anywhere from 420 to 600. And none of those patients have glaucoma. Makes interpreting the data outside of the narrow range who were done in the OAT study, which is what we're looking at, very difficult. This, on the other hand, is crystal clear. Every study, and there have been over 700 studies done with corneal hysteresis, the average in every population across the globe is about 10.5, 10.4. So when patients are below that 10.3 number, 10.4 number, they're at risk, greater risk. When they're above it, they have less risk. This is so universally applicable. I think that tool has made the assessment of the glaucoma patient and who's going to progress in glaucoma incredibly clear. This was one of the original studies. This was Neil Congdon when he was down at the Wilmer Eye Institute. Really beautiful study on progression. And pretty much what he found was corneal hysteresis is 10 times more sensitive in measuring potential progression of disease in glaucoma than pachymetry. Pachymetry, the only value pachymetry had was originally in the OAT study to predict future behavior in ocular hypertensive patients. And it does that reasonably well. I think the two together are a wonderful marriage. But as far as predicting progression within glaucoma, this was the first ever. The other part of this, which I think is really critical before we step into the PGA discussion, is this is the corneal hysteresis conversion to glaucoma. You can see this is really remarkable. This is a study by Felipe Medeiros and his group. And, we talked about hysteresis being glaucoma predictive as far as glaucoma progression in existing patients, and pachymetry being the opposite, being predictive of future behavior towards developing glaucoma, which it does. This study shows that corneal hysteresis is a much stronger indicator of future progression into glaucoma versus pachymetry. And if you look at this graph, it looks a lot like the OAT study. This is the Kaplan-Meier curve. It doesn't mean that you can't develop glaucoma if your corneal hysteresis is above 10.2, but you are, at the end of 5 years, almost 70% less likely. Very important tool. It also influences your IOP. So this is a really critical piece of information, because when you're interpreting your PGA outcomes, you have to measure it with the right device. The IOP-CC, which is an aura-based measurement, ocular response analyzer by Reichert, or Avatec now, differentiates multiple issues. But if you look at this graph on the left, the solid line graph, where it's Goldmann and IOP-CC and normalized, they're essentially the same. They don't differentiate. But in patients with glaucoma, you can see the glaucoma measurement for the Goldmann historically and typically is significantly different and wrong compared to the correct measurement, which is the IOP-CC, which is effectively the same as pneumotonometry. So IOP-CC and pneumotonometry line up like that. So you're missing 30, sometimes 40% of the patients relative to accurate measurements. And we just had an example today in the office when the students came in. I had them do a Goldmann on a patient. for their purposes and for their edification. And on the way in, the technician had done that, and they were masked against the information. And the gold mine was 18 or 19, I think it was on the right. It certainly was 19 for sure on the left. But the IOP-CC was 24.2 and 26.1. Big difference. That type of differentiation is critical if you're trying to assess the efficacy of a drug. So to know the true performance of the PGA, you actually have to know the true pressure. This is just a quick comment on what I think is probably the most important new technology out there. It's tonography. It's not a new technology, but it is a new way to gather information about the eye. I just told you that IOP by itself is so variable, and it is not representative of the disease. It's simply the one thing we can measure and control as far as efficacy. In the beginning, we can say, look, your pressure was 30, now it's 19. I'm happy with that response. Let's see what happens. But the reality is IOP varies all day. It's like if you took random blood sugars in a patient versus having an A1C hemoglobin. Tonography is the A1C hemoglobin of IOP. And for that reason, it's really arguably by far and away the best measurement you can achieve. We just didn't have a reasonable way to do it. Now there is. It's called the Falk multi-medical system. And what it really measures is the resistance to outflow over time. And if you look at the testing that's available, you can do tonography, which is the true outflow capacity of the eye. You can do intraocular pressure. This is standard serial tonometry. It takes anywhere from about 60 to anywhere about 100, maybe 85 to 90 measurements in 10 seconds. And that is qualified by the FDA for reimbursement and as a serial tonometry. And then ophthalmodynamometry, which is remarkable in every dimension, measures the true blood pressure in the ophthalmic artery on both sides, which is a direct correlate to the transmission of fluid from the heart to the brain going through the carotid system. So the number of patients we've picked up with significant vascular abnormalities with this test, I can't even count them anymore. So very important. But the real issue is this. IOP is directly related to aqueous humor production. The rate of aqueous humor outflow is constant, but the rate of production is variable. So when you're trying to measure the efficacy of your PGA use, when you have a system, let's say the patient comes in and the high IOP that you read was 25, let's say, and you come back and it's 21. You're thinking, oh, I wish I would have had a better response. Maybe I should add another drug. If you knew what the tonography was beforehand, and you measured the effect of the tonography reduction, which we do on every patient, you would understand the true value of your PGA. Now, we had a case the other day where 25 and 21 were just about the numbers, but tonography changed 34%. That 34% change is the real change in the outflow capacity of the eye. And what it means is you just didn't get the peak measurement of what the IOP could be. You found somewhere in that continuum of measurements that the IOP was. So very important. Let me show you this graph. This is a graph that Frank Falk has done and put out, which is fascinating. And if you look carefully, you'll see that the outflow versus the IOP. So if you have an outflow of, let's say, 0.2, if you look at that graph, what you're going to see is that the 0.2, and I can't see it because of the bar on the bottom, but the point, let's make it 0.3. You're looking, and that if you get that outflow at, let's say, 0.3, whatever that is, it will tell you that that patient's pressure will never be higher than that when they leave the office. You do not have that guarantee when you measure the pressure by itself. So a lot of issues when we consider efficacy of the drugs, and these are just a couple small ones. This is out of the old study. We'll get past that. Just a couple quick comments. Collaborative normal tension glaucoma study used 30% as their base. And as you can see at 5 years out, overall 80% compared with 40% control showed relative slowing and or cessation of progression. So they chose 30% reduction of IOP. We know that PGAs can generally get you that for most patients. We also know that in the EGMT study, they used 25%. Certainly, most of the PGAs that we use can achieve that, which I think is really important. The next is the results of the collaborative or the SIGIT study. Here, it was really a a number of different factors, but the bottom line was it was most effective when everybody's pressure was below 18. Actually, the average pressure in that group was about 13, but all measurements for those patients were below 18. And the surgery versus medicine did not have a substantial difference when everybody was below 18. So I think most PGAs typically can get you to that number as well. So one of the reasons PGAs have ascended into this remarkable position of use is simply because they're extremely efficacious. And if you look at the major studies that we've done, they really do hit the mark as to the ability to achieve that with single drug therapy for the vast majority of patients. So this is the study ages when they less than 18. 100% of the patients had no progression of visual fields. So let's talk a little bit about the pathophysiology of the drugs. We know that on the inflow side, we have beta blockers, CAIs, and alpha agonists. Alpha agonists are biphasic. Mostly it's on the inflow side. It's a little bit, certainly less so on the outflow side. Cholinergics, prostaglandins, and alpha agonists are on the outflow side. We now can add a new drug, which is a ROCK-NET inhibitor. More repressive, but mechanistically it's a little bit different. So PGAs fit into increased outflow. So if you have a patient who you're treating for intraocular pressure and they have a really gummed up system because they were uveitic or hemolytic glaucoma, the PGA probably isn't going to be your best choice. On the other hand, any of the drugs that block production are going to work really well, either oral or topical CAIs or the alphas or betas. You can use the prostaglandin because you will get some outflow improvement, but the better drugs are going to be, let's just stop production, and therefore we have less pressure on the system. So let's go past this one. Briefly, 2 comments about beta blockers. Number 1, very important. Beta blockers have significant long-term drift. Exactly opposite with your PGAs. Once you establish an effect with the PGA, every study, the travoprost study, the latanoprost study, and the bimatoprost study show a very high level of persistent behavior on the part of the drug after the first 2 to 3 weeks. Beta blockers, on the other hand, can show remarkable initial outcomes, but generally after about 6 months to a year, they settle into about 25%. So if you put that patient who's 25 on a beta blocker and they drop down to 16, that's tremendous. Reality is they're probably going to be closer to 20 by about 6 months out. So you should plan that in. On the other hand, if you have that effect from the PGA, and let's say that effect is 30%, if you do the math, that 30% will consistently be present. You may see the pressure going up and down, but that's because the IOP is varying. Consistently, on the other hand, for the outflow, you're going to see that 30% change in outflow. And if the drug's really working, that 30% change will be very stable so long as the pressure doesn't, as long as the disease doesn't progress. The other thing to remember is beta blockers do nothing at night. I'm sure everybody here knows that, but just repeat it. They have decent effect during the day and a little bit better in the morning than the afternoon, but pretty close. The bigger issue is at night, 0 improvement. So if you're going to add a beta blocker to your PGA, a little pearl, do it in the morning and use 0.5%. There's no point in using 0.25%. The differentiation is minimal. And if you're going to go for IOP, you want to go for the IOP that's the most important. All right. The other thing that's really critical to remember is if you're going to conjunctively use those 2 drugs, this is the LAMA study. It was published in AJO in 1102, so 21 years ago. I used this when I testified in Australia for their Supreme Court case regarding optometric therapeutic privilege, and we won the case, not because of myself only, but there were some really good people involved. But one of the pieces I had to do was submit the white paper to prove that beta blockers were safe. As it turns out, this is LAMA's conclusion. No scientific studies supporting the development of worsening claudication, depression, hypoglycemia, sexual dysfunction, or impaired neuromuscular transmission were recorded in any medical study of significance. The only really critical elements, this is what you want to remember with the beta blocker when you add it to your PGA, check the pulse and make sure that they don't have breathing issues, COPD, emphysema, and asthma. Those are the only 2 significant ones. All the others, interestingly enough, were sort of hype to make the drug look much worse than it was, to make it difficult for optometry to achieve the use of this drug during our therapeutic legislative battles 25 years ago. With this drug, if you're going to add it on, just remember it's just not nearly as effective as it is in a standalone setting. Timolol is actually reasonably effective. You're going to get another, you won't get 25%, but you'll get another maybe 2 or 3 millimeters. This one, my experience over 30 years of constantly using it, a lot of patients on it, maybe 10, 15% over a PGA. By itself, probably close to 25%. Side effects here, and I just had one the other day, I had a patient start, literally couldn't get out of bed 3 days later. There is that rare patient where this crosses the blood-brain barrier and produces a malaise. Otherwise, the primaries are dry mouth, and then over time, anywhere from this drug, maybe 10 to 15%. The generics, which you're going to get forced to because nobody wants to pay for the branded drugs, you're looking at 30% allergy rate over probably the first year and a half or two. So once that happens, no matter what other version of this drug is used, you're going to get the same allergy rate. So extremely high allergy rate. The reason why PGAs are such a good first choice. CAIs, average reduction about 20 to 25%. One of the little side effects here, which is really critical, CAIs burn like battery acid for many patients because the pH is very low and it has to buffer up. The second is patients who have fuchs or any type of cuttata, not a good drug because the corneal endothelial pump is driven by carbonic anhydrase. So if you block CA in the cornea and inhibit the pump, you're going to eventually get low-level fluid increase. Classic patient is somebody who's post-op, everything's looking good, they have some cuttata, maybe a little bit less than a full fuchs, and they start to develop pressures. You decide you want to stay away from the PGA because they have some CME, perfectly fair, and you go ahead and prosecute the situation, and then subsequently the patient ends up starting to see slow vision reduction. Make sure you get that pachymetry remeasured. Yeah, you might not see stria, you might not see folds, but you might add 30 or 40 microns of thickness because of the CAI inhibiting the pump. So just keep that in mind. Let's talk about the prostaglandins. This was the standard list of prostaglandins. We're going to talk about a couple of new ones, which are really exciting. Critically important, primary pearl. The XLT study, the best study ever done, exfrazalitan, right? Latanoprost and bimatoprost, right? So that study was done to compare head-to-head the relative efficacy of these drugs. And as you can see, in a double-blinded, placebo-controlled, multi-center study done by some of the top people in glaucoma in America at the time, and probably still to this day, there is no statistical difference between those three drugs when it comes to patient outcomes. Everything that you've probably decided your perspective on, whether Travatan Z or whether it's Lumigan, is primarily marketing. So no disrespect to the companies. This is the science. They all work really well. Now, these are the original drugs. These are not generics. You have to, we'll throw that aside. So just keep that in mind. All right, so what does a PGA do? Well, average for these three drugs in general is probably about 30 to 33%, maybe a little bit, about 30% probably better. They effectively change the outflow through the ciliary muscle system. They do have some capacity to induce change. So if you have a patient who's had a rough cataract surgery, rough would be a broken capsule or really a lot of corneal edema and swelling and maybe persistent inflammation, I would stay away from this drug for some period of time. It wouldn't prohibit me from using it. I probably wouldn't use it in that immediate post-op period. Uveitis occurs infrequently. I've used this drug in thousands of patients. I've had a few uveitises. In the study, they had 6%. I've never seen another study that's repeated that. So suffice it to say that if they have active uveitis, probably not the best drug to use chronically. But if you have a patient with an IOP spike from uveitic glaucoma, you need to use every weapon you have. And using this over 2 or 3 or 4 days to help lower pressure, it's not going to be a big jump, but it will definitely contribute enough that you'll see a difference. So I would use it certainly in conjunction with aqueous suppressant drugs. And then hypertrichosis, we all know, eyelash issues. The biggest one that causes patients to quit is periorbital darkening. And you have to do that. You have to watch that. It sort of sneaks up on you. Also, there's fat loss, and that's notably more common in patients who are East Asian origin, but you got to watch for that too. Other than that, there's really nothing topically. It is a Class C drug for pregnancy. I wouldn't use it. And the reason is prostaglandins are used to induce contractions and produce an abortion in patients who are pregnant. So I think we would all want to stay away from this drug during pregnancy. There are other drugs that are much safer, beta blockers being that drug. OBGYNs are very comfortable with that. Responder rates. This is interesting. So for patients at 17 and less, there's a big difference between timolol and the prostaglandins. And I think this is at 6 months to 12 months. So just remember, if you have a reason that you feel you shouldn't use a PGA, that's great, but don't expect the kind of pressure response that you're going to get with the PGA with a single application of timolol once a day. No real differences here. All three drugs have about the same side effect profile. Let's talk a little bit about our new age PGAs, which I think are super exciting, and I'll tell you why. I just showed you the average response at about 30%, and I'm going to show you some comparative data from the FDA clinical trials on both Rocklatan and Vyzulta, which I think are very exciting. So Rocklatan is a drug that is remarkably successful, minus the fact that it has some really serious side effects, and the redness and hyperemia kind of get in the way of its success. But the actual IOP lowering, excellent. So it's a combination of latanoprost, traditional latanoprost at 0.005, and a ROCKNET inhibitor, which is Ropressa. These are the side effect profiles you can see compared to timolol. They're remarkable. Timolol is a fairly bland drug when it comes to topical effects. The one side effect with timolol that I didn't mention, which is really sneaky and does show up pretty regularly, is that it can cause ocular surface dysfunction in the form of decreased tear production. And patients can actually end up with dry eye. So if I have a patient who's on a beta blocker and there's complaining of progressive dry eye, the first thing I'll do is I'll suspend the beta blocker. You need to wait about 2 to 4 weeks before you can get a legitimate assessment because the residual effect of the drug takes that long to clear. But that is rewarding probably at least half the time. So then just find something else to use. Verticillata are completely, they're interesting to look at. You see them most of the time. No effect on vision. I would never stop a patient as a result of that. The conjunctival hemorrhage tends to be early in the presentation. It's about 10% of the patients. That all dissipates. The hyperemia does not go away over time. And about 10% or so of the patients, 1 out of every 9, end up with hyperemia being so severe that they have to discontinue the drug. About 42% are mild, and about half the patients don't have any. So it's a worthwhile investment. I just want to warn the patients before I start. Why does it work so well? Because you're using multiple mechanisms of action, one through the uveoscleral outflow system and the other through the trabecular meshwork. So you're getting both ends of the egress or the outflow side of the equation. Brilliant concept, brand new MOA, first drug ever for true trabecular increase in outflow. Very nicely done. And I want to show you a graph here. This is what happens when you put that drug in the eye. But here's the important part. So every one of you, I'm sure, has had a request for either Vyzulta or Rocklatan denied. Now Lumigan even gets denied by Aetna, CVS Caremark, right? So this is why. This is the FDA study. So if you look to the left, you see the histobars. There is not a notable statistically significant difference if all you're trying to achieve for your patient is a 20% lowering. Now, we don't have a single study other than the OATS study, which showed that need, but that's what these companies are basing their science on, is the OATS study said 20%, and at 20%, it's almost the same. So the pharmacist is going to tell the patient, well, this is the same drug. It's not the same drug if you need notable IOP reduction. You can see here that if you're looking for 30% reduction, the beige or the pumpkin-looking color versus the green, the probability that Rocklatan is going to give you that 30% is twice as likely than generic latanoprost. It's almost 3 times as likely with, or 2.5 times as likely at 35%, and it's 300% more likely at 40%. So depending on what you need as your goal pressure, the selection of the PGA is really critical. And there are very few drugs that we should really be comfortable fighting for as far as expending time and energy. This is absolutely one of them, and the other one's Vyzulta. The response I see in my patients, I have over 250 patients on Vyzulta right now, and it's remarkable. I probably have half that many on Rocklatan, and probably a little bit less, maybe 100 or so. And again, the responses have been great, but those are patients who I felt needed a increased level or persistently present level of IOP reduction. 20% was not that number. So want to fight for it? I think you have good science to back that up. This is one of those inside pieces, but this is the FDA clinical trial. This is absolute solid data, and I don't think anybody in the science world can deny it. Here's the other side of that equation. It's Vyzulta. Similar in concept, basic drug is a PGA. The additional element is a nitric oxide donating drug, and it also affects outflow. Sorry about that. My allergies are kicking in this time of year. And nitric oxide is kind of interesting. Nitric oxide is probably one of the most universal drugs in our body. It supplies everything from smooth muscle relaxation in patients who are having heart problems. So it's nitroglycerin, right? You put nitroglycerin under your tongue, it immediately converts to nitric oxide. It relaxes the smooth vessels, the smooth muscle in the small vessels of the heart, opens it up, relieves the chest pain. Erectile dysfunction, all of the erectile dysfunction drugs have nitric oxide as one of the primary mechanisms of activation of blood flow change to the sexual organs. Platelet inhibition, cell growth and differentiation. It's a ubiquitous drug in the body, so it's very safe, and we are very comfortable with it. What's interesting is about 40% of your patients have in glaucoma patients, 40% reduction in the NO metabolite is consistently found in glaucoma studies, showing that patients who have a deficiency probably plays a significant role in why their glaucoma pressures are elevated. Lowering pressure can be done by applying nitric oxide to the trabecular meshwork. And they have about the same issue. Here you see the difference between the two. One's 9 and the other one's at 7.8. And, the companies, the pharmaceutical companies that are selling you the drugs would like you to believe that's significant. The pharmaceutical providers, i.e. the pharmacies and the PBMs, the pharmaceutical benefit managers, would like to think it's not. Just do the math. That's it's about 1.2 millimeters of mercury every minute of the day. If you do the math on that, it's about 800,000 millimeters of mercury a year. We all know that the treatment algorithm, the treatment metric is the lower the pressure, the better the disease management. Doesn't matter what drug you're using. This is enormously different. These are not the same drugs. So be sure to help your patient out by making the battle work. Sometimes you can't win it, but it's obviously worth it all the time. Here's another version of that. This is Vyzulta. Mean diurnal variation, almost 70% versus 50%. Huge differences in getting to that number. And here's the same general pattern that we saw with Rocklatan. Whereas if you want more control, latanoprost just doesn't get you there. So big difference. Here's that piece I told you about with persistence. Once that pressure goes down, it's incredible how sustainable it is. But this is a normal tension patient, and both Rocklatan and Vyzulta could do this for you. This is why the PGAs are so critical. Even the other PGAs are pretty good at this, but not quite as effective. Normally, if you have a patient who has a pressure of 19 and you're looking to lower it with a PGA, you're probably looking at maybe getting them down to 16 or so. That'd be pretty typical. That's still a pretty good response. Remember, I told you that differentiation is the higher the pressure, the greater the response. This gives you a 5 millimeter difference that's persistent for a year. This is the most significant study I've ever seen on normal tension use, and it's all about the use of a superior grade PGA to maintain that normal tension patient for you and keep that visual field preserved as long as you can. So a couple of quick pearls, colleagues. SLT versus PGA. One of the greatest studies ever done. This is Jorge Alvarado and his crew. And what they did was they did bench work where they looked at the trabecular endothelial cells, the Schlimm's canal endothelial cells. They exposed them to beta blockers, CAIs, alpha agonists, PGAs, and SLT. And what they found was that SLT and PGAs had the exact same mechanism of action on the cells, whereas the other three categories are different. So what does this tell you about PGAs after they've had an SLT? Probably might not be the best drug to add back, right? Typically, I do not add a PGA back after SLT. If the pressure is not good, I'll go ahead and start them on a beta blocker. The reason being I have two different mechanisms working for me. There's also another thought here. Oh, this is fantastic news. We have the first new glaucoma drug in a very long time. This is called IUZA, and it's by Thea, and I just prescribed it. I just got my samples today, and I just prescribed two patients. So looking forward to seeing how it works. But the key here is that preservative-free is really crucial. If you look to the left, those are all the preservative levels in all the current glaucoma products. And then if you look to the right, there's some alternative preservatives. And there's a few non-preserved drops. You have Kosov PF, Timoptic PF, Zioptan, and Latanoprost. And you might ask, why is this important? Well, we know from a number of different studies, including Badoon and some others, that the more drugs you have, the worse your ocular surface disease becomes. There's a little running joke within the running punk joke within the glaucoma community. That is that we create our own ocular surface disease. And in fact, it's not a joke, it's actually a reality. So to reduce the BAK load or the preservative load, it's wonderful to have a new drug in play. And IUZA looks to be that drug. You know, if you look at the data on preserved versus non-preserved drug, this drug was able to compete against the preserved drugs as far as IOP control, which Zioptan actually wasn't capable of doing. It had notably less IOP capacity. So they've done a really nice job of maintaining IOP control, decreasing the preservative load. And here, if you look at the switch, I mean, look at the difference between the inclusion in the 6 months when you've taken the patient from that drug to the IUZA. Very impressive. I'm looking forward to seeing that data coming forward. Another little pearl, compliance. This is the biggest study ever done. This is Nordstrom, Friedman, Quigley, 2005, AJO. And you can see that this is a battle that's hard to fight, colleagues. But using a prostaglandin gives you the highest possibility of persistent use of the drug over time. It's pretty amazing that the other drugs fall off after 12 months to levels as low as 10% use. PGAs consistently stay at about 30 to 40%. Now, with enthusiasm, with good coaching, with support, you can probably push that up into 60 or 70%. But the PGA is clearly your best friend. And part of the reason is this next concept, which is the actual effect of your PGA is closer to 48 hours, not 24. Once a patient's been on the drug for a while, it's quite clear that the dosing is able to be variable and can be quite comfortable at every other day. I'm going to give you a couple pearls with this, and I see this all the time in practice. If you see enough patients, this is quite clearly the case on a regular basis. Anytime a patient's on treatment and the pressure started, let's say at 30, 28, 30, and now they're above 30, and they come in at that 2-week or 4-week visit, probability is they're getting more than one drop in the eye at the same time. Leon Herndon at Duke published a really remarkable study of over 300 patients in which he demonstrated that using Lumigan twice a day could take pressures up into the 50s. So this is the only glaucoma drug we have where if you use it more, you have a paradoxical effect in a small percentage of patients, and they can rise to very high numbers. So when I see that patient come in, instead of panicking and saying, oh my God, let me move you over to this, I simply tell them, let's say every other day, I'll see you back in 2 weeks. Inevitably, when they come in, the pressure is 17 or 18. So be very cautious with the PGAs in that small group of people. Twice daily dosing can be dangerous with these patients. Even once a day can be too much in some patients who have high levels of endogenous prostaglandin. Not everybody has the same level of prostaglandin in their body. There's 6 different prostaglandin forms. We're using probably the most powerful with our drug. And when you put it in, there may just be too much there. Kind of like that SLT patient with the additional PGA, which can sometimes blunt the efficacy of the SLT by causing the pressure to go up a little bit because you have too much PGA. Same thing can happen without the SLT in these patients. This is Labovitz's work in 201. This was the original Vomatoprost study. And he was very bright because at the end of the study, he started watching patients after they stopped the drug And he measured IOPs for days afterwards, and he found the vast majority maintained the full effect of the drug for up to 48 hours, almost less than 1 millimeter change. So that tells you that you have a cushion. So alternate day therapy can work as far as IOP levels of control. It also can work because of the other alternative activities. As I said, SLT is less effective in patients who are on a prostaglandin already and those who are kept on a prostaglandin afterwards. I automatically stop my prostaglandin after SLT and just let the patient ride loose. If you need some control, add a beta blocker. The two work really well together. And also, it's not hard to do. You know, the average patient, all I tell them is either do it on the odd days of the month or the even days of the month and just mark your calendar and see what we get. I'm going to go past this one real quick. What time do we have here? Yeah, we're getting close to watching it. So here's another form of prostaglandin. It's Durista. This is bimatoprost. This is intracameral or intraocular bimatoprost. This is a new product that's been around about 2 years, about 3 years probably now. We use a ton of it at the office. Rob, my partner, Robin Harkin, uses it all the time. Love this drug. It has all of the positive effects of the prostaglandin with none of the topical effects. So the patient is left with his pristine, white, lovely eye, and they're getting really good IOP response. Actually, a little better intraocularly than you have topically. So it's because the drug doesn't have, worry about penetration issues. Here's what it looks like in the eye. I just had a couple patients today. Students love doing gonioscopy on this because it's kind of cool to see things at the angle of this, and the hydrus and some of the stents that we're using routinely. It's very interesting to go in and take a look at them and see how they position themselves into the angle. But this internal effect of the drug is exactly the same that it has externally. It uses the uveoscleral outflow, but because it releases the drug constantly in a really low concentration relative to a drop, you get this fascinating, persistent effect over time. Most of the patients in this study made it to 4 months for sure, but the vast majority of patients made it to almost 6 months. So it looks like then the second phase of the study was the use of the drug repeatedly. The first phase allowed it only to be used one time. This will give you the information that's, I think, most valuable, and that is that this drug can be used on an every 6-month cycle after it dissolves, and you can maintain really good IOP control with no topical therapy. Very exciting, and I think you're going to see several versions of this. Glaukos has a travoprost version of it, so the prostaglandins are not only effective outside of the eye, they're effective in the eye as well. And there was no increased risk of CME with this or uveitis, nor was there a change in the endothelial cell count of any substantive level. And here's the data from the study. This is the Durista study of 2010. I'm going to go back to this case real quick here. I want to show you something. So this is a really interesting case. Came in on latanoprost and alphagan. Pressures are 17, 16. And you can see here the gonioscopy was good. Early fixation loss in the left eye. Here's the right eye's disc. Not a healthy looking eye, but certainly about a 0.7, maybe a little more, 0.75. Definite inferior thinning and a little bit of change. But look on the left eye. There's an optic pit there at 5 o'clock, and there's a really nice wedge loss. This is a 0.75 to 8, maybe even a little bit more, and with clear cut all the way to the laminar rim in this eye. That's why the visual field looks like that, okay? So you have patients who are at goal, and clearly that number is too high for this person. At 40 years old, her pressure needs to be down to 12 or 13. So the switch was, I switched from latanoprost to Vyzulta, kept the alpha-GAN P in place. Pressure dropped from 17, 16 to 12, 13. Tonography accordingly increased, went up into the 0.28 range, and the patient's been very stable for a long time. So this drug class is one of the great gifts that we've been given as glaucoma managers. It gives us persistent effect once it's shown to be effective. It gives us minimal side effects, topical hyperemia, some irritation, minimal side effects, no systemic concerns. It has very few limitations in use. We talked about some of those. If you avoid them, you can maximize the use of the drug. And probably most importantly, it's forgiving in the sense that the patient can forget that drug every other day and still, in most instances, get a very good effect from the drug. So that's one of the reasons why PGA use has skyrocketed as primary therapy. And now we're just searching for better ways to apply it. I didn't put this in, but there are two other companies that are in the process of releasing intracanalicular PGA sustained treatments. One is a drug called Dextenza. Well, Dextenza is the company that's Ocular Therapeutics. Dextenza is our current drug, which has a dexamethasone in it. And the other one is a company that has a intracanalicular system that's going to use travoprost. So the PGAs have become the dominant drug form. So we have them both in topical form, we have them in sustained release form, both outside the eye and inside the eye. And I think going forward, we have obviously the new drug I use, which is very exciting. We'll see how that works out. PGAs are the future of treatment. This is interesting for one final comment. I think we're just about ready to finish up. Jen's going to jump on here. This drug is capable of being used by optometrists in at least one state in America. I've had a discussion with them, and I'm super excited that they're able to do that. So